Good morning, everybody. Welcome to this question and answer session. My name is Mary O'Keefe. I'm going to be moderating this session. We're delighted to be joined by three experts today. So we're joined by Jana Geertmolen, Francesca Oppitz, and Boris Zerniko. So we're hoping that you've watched the talks that they've completed on the EFIC Academy. And if you have any questions, please jump in and ask. They're keen to answer, and it'll make a better session if you ask questions. We have an hour in total. It doesn't have to run for the hour. So if there isn't a lot of questions, we can cut it short, but we have the hour. So maybe to start us off, we'll get our speakers to just introduce themselves briefly, and then we will start the question and answers. So Francesca, would you like to go first? Do you want to briefly introduce yourself?
Yeah, good morning, everyone. My name is Francesca Oppitz. I'm a pediatric anesthesiologist. I'm working in Utrecht. That's a children's hospital where we take care of children of all ages, and we are a huge oncological center. I'm expert in acute pain in children, and above all, my interest is in quality improvement, postoperative in children and regional anesthesia.
Great. And Boris?
My name is Boris Zerniko. I'm a pediatrician, and I'm the head of the German Pediatric Pain Center, which is located at a huge children's hospital and Wittenherdecke University. And in my department, there's also a palliative care unit, so the first one for children in Europe. And we have a huge outpatient department. And my interest is especially in chronic pain and pain education and research.
Great, thanks, Boris. And Jana?
My name is Jana Geertmolen. I'm a neurologist and pain specialist and have been working in the Department of Neurology, doing research mostly on chronic neuropathic pain and treatment of chronic neuropathic pain. And since January, I'm the head of the interdisciplinary pain and palliative care outpatients unit at the University Hospital of Kiel. So I'm now also working with acute pain for the anesthesiologists, but my focus is still the chronic neuropathic pain.
Great. And just to inform the audience, Jana has to leave a bit earlier. So if we're asking questions, we might go in that order that we ask Jana's questions first. So at the moment, so people I think are still trickling in. We don't have any questions at the moment, but I'm happy to kick it off. So Jana, your work, I'd like to know a bit about how pain actually affects sensory profiles. So if we're looking at painful and non-painful neuropathic conditions, do we know if there are huge differences between the different types of non-painful and painful conditions?
Interestingly, there are no differences in the somatosensory profile of patients with painful or painless neuropathy. And the reasons for this are still unclear. It's a little bit disappointing for us too. But the solution is probably that there are so many different mechanisms of pain playing a role in the patients, also regarding the biopsychosocial model of pain, that we cannot solely see it on the in the findings. We also have to differentiate that every report about pain or pain characteristic is a subjective impression of the patient. And what we measure with QST is our evoked somatosensory findings. And they do not necessarily correlate to what the patient says. So with anamnestics or questionnaires, we assess the subjective impression or perception of pain. But with QST, we investigate mechanisms of pain, and that seems at least to be different, or something different, and that might explain why we do not find similarities or the same findings up on QST, and that's what we find in the questionnaires.
And is there research ongoing to kind of reconcile this measurement of sensory profiles and the patient experience? Are we getting closer to maybe better stratifying certain profiles and developing better treatments, or What is that area?
Yeah, definitely. That should be the focus, and it is the focus of the current ongoing studies, I think. The study about painful and painless neuropathy and the QST profiles was published just last year, I think. So until now, we definitely need to, as in every pain area, to define better outcome parameters that include what we know from the palliative care total pain, which includes not only the subjective perception, but other variables as well, influencing factors.
And how close are we to developing better mechanism-based treatment? So if we take any neuropathic condition, the patient presents with very different sensory signs and symptoms. According to the evidence, a lot of these patients get a kind of a uniform treatment, like a similar pain medication treatment. But you can tell us, based on your work, that there's probably different mechanisms at play for all these symptoms in the same condition. The trials you're speaking about, what kind of mechanism-based treatments are they moving towards? Like, can we be confident that, I don't know, a few decades from now that we'll have better treatments or more individualized treatments?
I hope so. That is the aim of the studies as well, to individualize treatment based on the mechanisms that are underlying the disease. Meaning, for example, I mean, the current guidelines still focus on neuropathic pain and first line, second line treatment, independent of what the underlying mechanism is in the patient. But still in the clinical routine, I try to somehow use the mechanism-based idea. For example, if I have a patient who has strong peripheral sensitization, like with presence of heat, hyperalgesia, and strong burning, ongoing pain, I try to, or maybe also stinging pain, I sometimes try to use sodium channel blockers, for example, in those patients. If the other treatments didn't work, for example, if I have a patient who has severe allodynia, for example, where I know, okay, there is a central mechanism involved, I maybe try to use, for example, gabapentin and pregabalin first before the other analgesics, but that is only kind of experience related at the moment, because we don't have that many studies that definitely enable us to make guidelines for first, second, and third line, depending on the different mechanisms. That is too early, but we hope, and that is the idea of phenotyping the patient, that this might be possible in a few years.
So so for you as a clinician, you're doing some kind of experiential trials of these things, but the clinical trials are ongoing into these types of approaches to see. Right,
the clinical, a lot of clinical trials that I know so far are focusing on certain mechanisms. So the idea is that not every patient with, for example, postherpetic neuralgia is included in this trial, but only patients with postherpetic neuralgia and presence of allodynia, for example, to more homogenize the patient sample and to tell whether one certain substance is useful for one mechanism. That is the idea, and that is currently ongoing, but we don't have published studies so far that you enable us to rely on these and use the mechanism-based treatment, evidence-based.
Okay, and where a patient has maybe high levels of depression or catastrophizing or other psychosocial factors, how does that influence a patient's sensory profile and pain? Or is that something that's, again, it kind of creates...
Yeah, that is difficult to say, because of course we know that pain catastrophizing and depression increases the perception of pain, or increases the subjectively perceived intensity of pain. But I think, and of course QST is a psychophysical method. It is based on or it relies on a good compliance of the patient. But you can also use this QC, and you can, if you are a little bit known, you can relatively be sure that what the patient reports upon QST is a reliable measurement. But of course, it can be influenced by pain catastrophizing and depression. Yeah.
Yep. And one question, more of a practical clinical question, is that in your talk, I saw there's different devices to measure as part of a quantitative sensory testing procedure.
Mm-hmm.
If you are short on time,
Mm-hmm.
what are the main ones to use? Or even, yeah, I guess the most easy to use bedside devices, because in the lab, we can be using a lot more, you know,
Mm-hmm.
expensive devices that give us more information. But if we don't have that time, is there certain ones easy to use at the bedside that you'd recommend?
Yes, definitely. I mean, there is a bedside test that has been described also by our working group with Professor Baron. But you can, of course, in the clinical routine, I think it's important to use warm and cold perception for investigation of thin and unmyelinated fibers. Then the sharp and blunt pressure testing, like also for a differentiation between thick and thin myelinated fibers, and of course investigation of paresthesia and normal sensitivity. And then it is important to investigate all 3 different kinds of nerve fibers: the A beta fibers, A delta and C fibers. And I think that is the minimal program you should do. Okay. In order to get an impression. Of course, this is with this small investigation, it does not enable you to tell or investigate the mechanisms behind that, because you will not be able to detect an overactivity of nerve fibers. You will only be able to detect a functional loss.
Okay. I think we have a question for you here. I think it
Mm-hmm.
says, I'm wondering if there's a role for RTMS, MERT for NEP management research base, or any plan to implement that. I will be happy to get involved if there is.
There are a lot of studies on RTMS and non-stimulation, I think, still ongoing because evidence is still low. In my group, I've not planned any research on that, but it's definitely something that, at least in small trials, has been shown to be effective, and there is something that's worth to investigate it further.
Great. Yeah, and he said, I'm happy to get involved if there is.
Okay. Actually, I don't have a study running on this at the moment, but yeah.
Yeah. So yeah, that was great. So I don't have a background in your expertise, Jana, but it's very similar to other pain areas in that people are trying to progress the idea of individualized treatment, better understanding phenotypes, so we can get towards more, I guess, targeted or precision type treatment that we probably don't have in the guidelines at the moment, where everyone kind of gets a similar
right.
treatment.
Yeah.
Yep. So I'll just encourage people listening in, please get in with your questions if you have any. But in the meantime, I can ask a few. So Francesca, your talk was very interesting on the academy. And the first thing I was interested in is, I'm from Ireland and we don't have the same access to maybe acute pain service that you were talking about in your presentation that looked very comprehensive. This is relevant to Boris's presentation as well. This interdisciplinary approach that looks very impressive, very comprehensive, and that if a person could get it earlier, they'd probably be better off. Is there anything you could say around access to these treatments? So if you don't have access to that type of pain service, what's the next best thing that a person could do that maybe needs that?
Okay, I think you mean in an in-hospital setting.
Yes.
That acute pain service. That's an ideal state. You have such an acute pain service. And I know that a lot of clinics don't have such an acute pain service for children, but it's very necessary to provide for major surgery, for instance, PCA, patient-controlled anesthesia, and regional anesthesia with catheters for a longer time. So that's the ideal state. And of course, it's ideally we have also psychologists, and so you have it mostly in the big children hospitals. But of course, children are get operations also in smaller institutions. What you can do is, of course, the recent literature says use regional anesthesia, because we have convincing safety data regarding infections and nerve injury. There is no problem. The problem are more medications we use in an off-label manner or so. So use acute treatment. And if you use regional anesthesia, for instance, as a single shot, and you combine it with adjuvants such as clonidine, you can reach up to 12, 16 hours. So the first night is an excellent pain therapy. And after that, maybe you can use paracetamol, NSAIDs, such things, and not opioids anymore if the operation is not too much. So in the first place, you can use also regional anesthesia. You don't have access to acute pain service, but then in a little smaller one, but use it, yeah.
Yeah, and after, let's say for post-operative pain, if you have to provide something like an opioid, I don't know how prevalent that is, that certain children get an opioid. I'm not sure of the data on that, but is there any data that children stay on that medication for a longer time period than needed, or do you have any sense of what's going on in that space?
We have little data. Unfortunately, you don't believe it, but it's true. We have a little data how long takes pain after operations in children. For instance, we have a small data about strabismus operations. I know that a lot of anesthesiologists don't give opioids, but probably the first 2 days, actually, it's necessary. So we describe less than we need, that I know. And then we have data from America, from Monito. Of course, in America, we have the huge problem with opioid abuse. But there is described then if you have major surgery, in 30% of major surgery, I'm talking about scoliosis operation and pectus excavatus operation, in 30%, they need opioids, the children, longer than 7 days, and sometimes 14 days. And at that moment, patients are at home. So if you ask what's the relationship, very often children were discharged without an opioid, also in smaller operations, strabismus, tonsillectomy. But we know there is a need for, and in a tonsillectomy, for instance, they have a severe pain sometimes to 7 days, 14 days. So that's a lack of knowledge. We don't know how long pain takes in children.
Yeah. And are there studies ongoing into that, like observational studies that track these children when they go home, or is that an ongoing area?
They are not really, and that's also a problem. It's very difficult to conduct studies in children, and post-operative pain is, the anesthesiologists look at the door from the recovery. And that's really a problem. We doesn't know what happens after it. I know that in the pain out program, at least we look at the first 24 hours. That's what we do at the moment, and we are shocked about the pain we see now. 24 hours. In children, we never thought that they need more than a single shot regional anesthesia, for instance. So there's a lot to do.
Yep, like a lot of areas in pain, I guess. Yeah. And how does it work between when the child is in hospital and you're considering discharge from this acute pain service? It seems very hard to go from there to transition home. How does that procedure work? Like, what outcomes do you measure to decide, okay, this person can go home?
In the Netherlands, we have a high percentage of outpatient. There's a lot of operations in Germany stay in the hospital, and in the Netherlands they go home. Mostly these operations go home without an opioids. They get non-opioid analgesics, and I have to be honest, we don't know what happens at home. The surgeons see them afterwards, and I think the problem is that the surgeon is asking, how do you feel? And they don't want to disappoint the surgeon, and they feel fine. So we don't know what happens at home. If we have major surgery, they stay some days in a hospital. And if we have the impression they need more support, they need a longer time opioids, then in our hospital, we have a chronic pain team, and they make the transition. They have contact with the general practitioner, and they talk about what medication is given with the patient and how to taper out the medication the following days, and what support is necessary. That's with the major surgery.
It seems that that's a quite impressive system that you're talking about. There's a lot of interactions between the team. I just worry in other countries that they, what happens, the child that doesn't have that team, that doesn't have that communication.
But that's, for instance, the problem in America, I think. They go home also in a high level of outpatient, and they go home with opioids. And if we do so, then we have a plan. And there are guidelines for chronic pain, if using opioids in children from 2020, I think, but it also applies to acute pain. It's exactly the same. You have to look at the patient. Are they risk factors? Are they depressive? Do they have anxiety? What is my plan with the pain? What needs the patient? Have to stay the patient longer in hospital, or is it possible to all the support they get not to go home? So yeah, that's important. Otherwise you can't deliver a high quality of pain treatment.
Yeah, you referred to depression there. Is that something that's formally assessed pre and post?
No, not in our hospital, but we know that we are very concerned about our scoliosis children. We know there is a relative high percentage of chronic pain afterwards, also in orthopedic surgery. And we also know that in children, one of the risk factors is in subclinical depression. But nobody knows how to measure it. That's something for a psychologist, but we don't measure this in patients before the operation. Yeah.
Okay.
Unfortunately not.
I might actually, it seems relevant to put this question to Boris on psychological assessment. So Boris, if you were to measure depression in a patient with pain, whether it be acute pain or chronic pain, what would be the best way clinically to do that?
There are screening tools that are validated even in the group of children with pain. So you can use validated screening tools that are validated in your language. Since we are a European academy, it doesn't make sense that I give you the name of the German instrument, but I know that there are instruments in every country that are validated to screen for depression. And it's easy to use, so it's validated. And many of them are free of charge. You can just get them through the internet, and they have to be validated in your language, but it's easy to apply.
Right.
The problem is what to do. Even if you have a child with a scoliosis and the indication is right to treat the child, and you see a major depression or even a subclinical depression, whatever, the question is, what do? You have to do this operation if the indication is right to do the operation. So, and you have to care for the child like you care for every child from the biopsychosocial perspective. And it doesn't matter whether the child is depressive or not. So you can prepare yourself that it might be harder to care for the child with a depression But nevertheless, you need a person who could care for the child. If you don't have this person, then what does it help you that you know that this child is at risk? So you just should measure things that are relevant for the child, for care for the child, not just because you are interested in.
Yes.
And that's your ethical responsibility if you measure things that you can act appropriately.
So
and anxiety is even more important than depression in young children. In older children, that's where Franziska is referring to. Children with scoliosis who receive major operations are often older and adolescents. And depression might be more a problem. But in very young children, anxiety is more a problem than depression. And anxiety of the parents is a problem. So you should screen whether you have anxiety in parents. And drug abuse is a problem in parents. So it's not the problem that the opioids are misused by a 9-year-old, but the problem is that the opioids are misused by the parents or the sister and brothers, the older sister and brothers, or the aunt or whatever. So it's a complicated thing because pediatrics means not caring for children, that means caring for families. Because the family is caring for the child at home. So you have to take this into account when you prescribe an opioid.
of course, yeah. And Boris, you said about not measuring things for the sake of measuring, that if we measure something, we should have a pathway on how to treat that measure. Does that have implications for who does the measurement? So should, for example, can a physiotherapist use a depression screening scale? Or should that be kept to a specific discipline?
The point of view on pain, whether it's acute or chronic from our institution, is that you always need a team. And you don't need a physiotherapist, an anesthesiologist, and whatever, a psychologist, you need a team. And who gives the screening tool to the parents or the patient doesn't matter.
Right.
When the team is assessing it and the team decide what to do. And if you don't have a pain team like Franziska has described in her talk, you should think about a structured approach. You have to adopt it to your hospital, but it should be a real written procedure, not just if Hermann is in charge, he does it in that way. And when Janet is in charge, it's been done in this way. But it should be a very structured thing that's reliable for the parents and the patients. And then it doesn't matter too much whether you have a team of 10 people or just 2, then they work as a team in a structured way.
Yeah, and I think what you're saying there about one person having their approach and another person having, that's what we see happening, I guess, in a lot of countries where there isn't a structure, where, it's more haphazard, it's a bit random what type of treatment a person gets. I have a question on outcome measures in terms of time. So in your clinic, Boris, if it's a patient with chronic pain and maybe you have limited time, what kind of measures should we be focusing on? Like our primary measures, like if we're looking at pain, we're looking at behavior.
No, you don't look at pain. Pain is not important. If you have chronic pain, it doesn't matter whether the patient tells you it's 2 or 10. It matters whether the patient is going to school or not. So measure whether the child is going to school, how often he or she is going to school, how often she goes home from school in the last 4 weeks. That's important. Measure whether she can meet friends. So the disability is important. And you can measure this with a pain disability index or with a functional disability index. And then you have to measure all the emotional things like anxiety, depression, you have to have looked to things like post-traumatic stress disorder, dissociative symptoms. That's important, but it's not important the severity of the pain score. It doesn't matter at all. I know that you have to ask, yeah, how strong is the pain on a scale from whatever 0 to 10. But for us in the clinic, it doesn't matter at all.
I think this is very interesting because other researchers would probably disagree with you. Like, this isn't just in children or adolescents. This is a topic, this is a conversation that's had in adult research, low back pain research that I do, is that the measure that's most important to the clinician and the measure that's most important to the child. So has there been work into that children and their parents are happy to focus on function over pain recovery, or is there any data on that? Because I think I know that has led to a lot of arguments and debate amongst researchers in terms of what they set as their primary outcome measure in a trial.
In chronic pain trials, pain could never be the primary outcome. That's ridiculous. And in conversation with families, it means that pain is a major feeling of the child, and you have to take it seriously. You have to speak about that. But after the child recognizes that you take it seriously, then you can focus on the real problems, like school, family, friends, function. And of course, you ask every 3 months, whatever, yeah, how severe is the pain? But if you do it in a multi-professional, multidisciplinary approach, it becomes quite clear what are really the problems in the families. And then they no longer speak about pain values. They speak about interaction or going to school, or that the parents want to divorce or whatever. And they don't longer speak about my pain is 8 of 10. And on our pain unit, we don't ask for pain severity, and we don't speak about pain severity. Nobody is speaking about pain severity.
That's very interesting.
Yeah, that's normal for us since 20 years. I think it's normal for every pediatric pain unit in the world who is providing an interdisciplinary and multi-professional approach, that the pain value is not of importance.
I think I agree with you that from a clinician perspective, that could be the case and you could reach that with the patient. But I guess what I'm wondering is,
it's pacing and leading. You first have to speak about this approach, and you have to educate the child and the family on, yeah, you have to welcome them and whatever. You have to appreciate their thoughts, their feelings, and then you can lead them to what are the goal that you and the family have. And the goal is to live a happy life and not to live a pain-free life. Life is never pain-free. So it couldn't be the goal to get rid of pain. Yeah, it could be a goal to get rid of chronic pain, or to go to school, to meet friends, to have a girlfriend or boyfriend, whatever. Yeah.
Yep. And I'm just wondering how do you go about this approach when, I guess I'm just talking clinically in Ireland, if a parent and their child come to the clinic and maybe they have misconceptions about what pain is, they equate it to damage, they have lots of other beliefs. How does that process start in your team to pick apart the experience?
We are a tertiary center, so the parents have a long journey, and then they arrive, and then we have more than 2 hours per family, and we always see the family with 2 persons, a pediatric pain expert from the medical side and a psychotherapist for children and adolescents. They never meet just one person. It's always simultaneous interviewing. For every date they have in our clinic, it's simultaneous interviewing. So they can feel that it's something different than the normal approach in the normal system.
I see. That makes sense.
So, and I'm rearing this because I have to go to the palliative care unit after this. But when I'm on the pain unit, I look like you.
Right.
And the psychologists are looking like you. And when the parents and the children are coming to our department, we say, I'm the doctor, and the psychologist says, I'm the psychologist. But after half an hour, the psychologist is speaking about the biological component of pain. And I'm speaking about the psychological and the social component, or even the spiritual component. So for the parents and the children, it's not quite clear whether I'm the physician or the psychologist. And often the psychologist educates the children on the use of triptans in migraine, for example. Yep. So it became totally interprofessional. And for us, it's not, this is bio and this is psycho. It's always everything together. And this is important, that the parents and the children, they feel that this is the right way. And we are not just talking. And then we have all these movies that are made for parents and children, and funny movies. And then they meet other children and adolescents on the unit that had that were on the unit for the last 2 weeks, for example, and they arrived in a wheelchair, and now they are going to school, for example. So they can see that it works. And this is extremely important, that they hear and see from the peer group that our approach is working. Then they are more convinced than when adults talk to them.
You spoke about movies, and I'm hoping everybody listening today saw that movie with the 2 eggs talking about migraine, like the educational movie. I have 2 questions. One, can people access these movies online? Are they free?
Yeah, they are free. Yeah, they are freely available on our YouTube channel. The German Pediatric Pain Center has an own YouTube channel. And if there are people who want to produce this movie in their language, they just can contact us, and we do this. So they provide us their language, and we merge the things, and then we provide the whole movie to them. We have done this with our pain movie in, I think, more than 30 languages. So you can access this even in Chinese, Japanese, whatever. Yeah. Latin, we have a Latin version, I think.
Yeah. Can you repeat the name of the YouTube channel, actually, just in case the attendees?
German Pediatric Pain Center, and it's in German, so it's Deutsches Kinderschmerzzentrum.
Yeah, because
if you are seeking for the German Pediatric Pain Center, you find our web page, and on the web page you can see everything. And if you go to the chat, you might find it in the chat as well.
Yeah. So Melinda has put it in the chat. One question a further question on the movies, and this is more of interest to other researchers and attendees that might be interested in applying this concept to other conditions. How were these developed? Were they co-designed with parents and children? Were they tested in some survey or study? Or
yeah. Interesting question. So first of all, we do a systematic review, because we just want to put things in the movie that is really evidence-based. For example, many people think that drinking water helps children with headache, but there's no evidence for this. So we don't put in this movie, drink water all the time.
Yes.
So, or don't eat chocolate, or whatever people want us to put in the movie. So we do a systematic review. And after the systematic review, we write the text of the movie, the first version. And this version goes to many, many people. And the people comment on this version. Then we review the text of the movie, And then we meet with your artist. And we are always 2 or 3 people who meet with an artist. And the artist is a very famous one in Germany. And then we developed a script, so pictures on how to put the words into movie scenes. And this takes a long time. So for a movie like this migraine movie, it takes more than 6 months to produce these scenes from the text. And I have seen many other movies, and those movies can be done in 3 days. It's always the same. You put things into a camera and put things out of a camera and whatever. These are special techniques, and I can produce such a movie in 3 days. That's no problem. But if you want to produce a movie that really is fun and really surprise the people, then it needs time and experts, movie experts. And then we put together scene by scene, and we review this scene with experts and patients. And this takes, again, I think half a year for such a movie to review scene by scene. And then the movie is finished, ready to go. And then we do the music of the movie. And this is done really by experts on movies. So they do nothing else than music for movies, for big movies. And they produce special sound effects and sounds for the movie. And then it's ready. And if you produce it in Germany, at least, it costs between 20 and 40,000 euro.
That's amazing, because a lot of educational resources that are developed for adults and children in pain don't have that expertise. That's why I'm asking, you know, how were these produced? Because they look really professional, they look really engaging. So that's really good to know for other people.
They are awarded. So this migraine movie is the best scientific movie in Germany in the year 2016. So there's a competition running every year of scientific movies, and it won the first prize. So
that's great.
But it's hard work to do.
Yeah, I have a question to follow up on that. So the movie is aiming to educate the child with chronic pain. That's correct? That's
and
the main
parent. And the
parent.
Yeah.
In terms of delivering this as part of a treatment, what in the education, what is it changing to get a person functioning better? Is it changing, do you think, beliefs, confidence, depression? What's the mediator, do you think, of this movie? If that's if you know it at the moment.
Yeah, I think education is the basic. If you think that something is wrong in your body, in the sense of that something is broken, you ask physicians to fix it. But if you have other ideas, so cognitions on pain, then other things are following and cognitions are changed. So the concept of pain and not depression. So to really change things like emotions, it always takes months to years. And sometimes it takes lifelong. If you are depressed as a child, then often you are depressed as a young adult and even as old adult. So to really change a person who often is depressed is really hard. And you can just change a little bit. You don't just fix it. But what you're doing is you change the idea about what is pain, what is a migraine. And if you watch the migraine movie, we always try to find positive things in it. So migraine is a bad disease to have. It's a disease of the brain. But there are positive aspects. You have a very fast brain. No brain, no pain. You're a smart person and you're smiling now. That's what we want to achieve in our patients. We want this smile you had just now. So they often feel deficient. Is that the right word in English?
Yes.
Yeah. But they should feel strong. to overcome a disease. So we always try to put in the positive aspects of a disease into those movies.
That's great. I'm just going to bring in Francesca. These types of movies that Boris is speaking about, this type of educational or engaging activities, is that also relevant in your setting, maybe as a form of distraction?
That's really relevant. In our hospital, we have a lot of effort for preparing children for operations. I mentioned earlier scoliosis children. They get an app, and with the app, they can prepare themselves for the operation, because they are seen 6 months or so for operation, and there's a lot of time. It's very important that they can handle their own pain. And I fully agree with Boris. We only talked about pain. Also in acute pain, the last years is a change. Of course, we measure pain. We have to treat acute pain, but the emphasis goes to the comfort, the functional of the patient. We measure, is the patient able to sleep? Sleep around an operation is one of the predictors we think in the future we have to focus, to target. It's not the pain, it's sleep. Can the patient eat? Can the children play? Is all these things are functional, then it's not necessary to give a lot of pain medication. And some year ago, a nurse at the ward had to give at a pain level of 5. Yeah, you measure pain of 5. There was a cutoff of 4. They had to give opioids. We are away from that. We do not so. If the patient is functional and if the patient is satisfied, then we are then they need no opioids, for instance. And the other tendency we see in acute pain is we also focus on side effects of pain medications. That's very important. If you have, I mentioned the scoliosis, if you have a child of a teenager who have vomiting the whole night because of a high amount of opioids, they will not be satisfied. And if you ask these children of teenagers, nearly always say, "Oh, I will have the pain and not vomiting." So that's you have to seek for balance in this. That is a huge development the last years. And preparing, we have and focus on therapy of anxiety in these children. So we started a project now with distraction, and children from 6 years. So the younger one, 4 years, we are really, it doesn't fit. So from 6 years, we started a study, perioperative. There are nearly data at the moment, how we can influence the pain around operation if we take care of anxiety, of distraction. We have, and that's luxury in the Netherlands. We have, we noem het pedagogische medewerker. They are women, they come with the children, and they are only for distraction at the operation theater. And if we have very excited children, then they also prepare the children with distraction. So preparing children for operations. And you don't have to forget, acute pain is also procedural pain. The most feared children in a hospital are needles. And around operation, you have a lot of contacts with needles. So we're focusing also here on non-pharmacological measures, and that's distraction with all the things Boris mentioned. Yeah. Yeah.
And what about virtual reality as a form of distraction? Is that something that's becoming more common, or is it more in the research area more so than
it's we have there is evidence that in procedural pain is effective, but we have nearly data about perioperative. So that's the study where I started, also major surgery, to look if therapy, distraction, therapy of anxiety with the real before the operation, at the recovery, and afterwards on the ward, can influence pain and pain medication, the use of pain medication. And that's a very interesting area. It's upcoming.
Yep.
And children and teenagers love it. So they are in another world. That's amazing. Yeah.
There's
The
a
other hand,
question.
I think, on the other hand, it's extremely important in invasive procedures that children, when they're old enough, have control over the procedure when they, on the parts of the procedure where they are allowed to have control. So when you draw blood, it's very important to ask the child, should I take the left hand or the right hand? And should Francesca doing the blood drawing, or should Boris do the blood drawing? So the child has to have control about some things. The child could not say, I don't want the blood drawing, because it's important for the treatment. But there are other things that the child can control. And in virtual reality, it's hard to have both distraction and control. So you have to balance this, that the child is in control of the procedure, on the other hand, is distracted by special things. And sometimes really computer screens with movies and singing and laughing and other things might be more appropriate than wearing glasses that completely shields the child from having control over the procedure. So this is a very, very, I think, from my point of view, an important thing to discuss when you use these new technologies.
And children, you have to approach individually.
Yes.
So as Boris says, there are children, they want to fully control. They want to see what I'm doing. I have to explain what I'm doing. And there are other ones, they don't want to know what to do now. So it's other than in the other way around than in adults. In adults, you have more protocols. So a child, you always have to approach individually.
So it really shows the importance of communication, as well as any other treatment that's going on. You have to be a good communicator, and the child needs to find you engaging and trust you as well.
And I think a huge difference between adult care and children care for children is that we always try to incorporate the parents or even the siblings. So I think it would be a good idea for people who are caring for adults to take in more the relatives or the partners or whatever, the friends of these patients. Because if you do, for example, preparation for an operation and you prepare the parents, and the parents are calm before the operation, the child is calm as well, because the child is always looking to the mother. And if the mother is convinced that Francesca is doing a good anesthesia, then the child is convinced. So it's more a team on this side, the care providers, but there's also a team on the other side, the family. And it might be helpful in caring for adults with chronic pain as well, if you have more often the partners involved.
I agree, because if you think any patient is only with us for, as clinicians, maybe 2 hours max, and they're giving the rest of their life with their partner or family.
Yeah.
So, you know, their partners and family will have a huge influence maybe on how they perceive their experience as well. So I agree. I think that's all we have time for. That was an excellent webinar. I really enjoyed it. I learned lots. It's not my background, so that was really engaging, really good. And yeah, I think we can end here. Thanks to all the attendees for coming and listening. And thanks to Francesca, Boris, and Jana for joining us and being so engaging and eager.
And perhaps a short idea for the next EFIC Congress, which we all attend, is that this kind of speaking with each other is very important, and I think really helpful for everybody. And I attended seminars on this Congress where I were not allowed to ask the question, but I should put it into an app. I traveled to Dublin, hundreds of kilometers, were sitting there and were not allowed to interact with people who were also there in the room, but should do it via an app. And I think this is the wrong way. the interaction between people, experts, in a direct way is extremely important. It might be with Zoom, but really to ask question, to get an answer, to ask the next question is extremely important.
Yeah, and that's something we had a component at the Congress last week. So we had something called EFIC TV, where me and another researcher called Morton interviewed people about topics. So that's something we can organize for the next Congress. We can do it again, and we can have more of these discussions that emerge into different areas.
You shouldn't have sessions where people traveling 1,000 kilometers to Dublin, sitting there, and they're not allowed to speak with the people who present. That's ridiculous, really. Then I could stay at home and do everything via TV or my screen. But that's really a special situation when you're sitting in a room and you should use your mobile to ask the person who is 5 meters away.
Sorry, Boris, I'm going to interrupt you here, but thank you so much for sharing. We'll definitely take this on as valuable feedback, but it just extends the scope of this webinar. So I appreciate all of you taking your time. Please join us on the education platform and let us know what you thought about this webinar. Have a wonderful rest of your day and your week. Thank you so much, everyone.
Bye.
Thanks. Bye.